Welcome, everyone. Thank you for joining today's session. I am Joe Junta, and I am the Marketing Associate of EverEx. I am joined alongside by Ellen Morello, U.S. General Manager of EverEx, and Suzanne Sanford, CEO of Vineyard Complementary Medicine. Suzanne and Ellen, can you introduce yourselves to the audience, beginning with Sue?
Hi, everybody. Again, Susan Sanford. I run a private practice on the island of Martha's Vineyard, hence island, the name of the webinar. My practice is a multidisciplinary interprofessional practice that incorporates physical therapy, acupuncture, massage, and chiropractic. We are a seasonal practice with a lot of transient people coming for the summer, leaving for the winter, a lot of year-round people that come and go just because, we live on an island. And so we do a lot of remote work and very seasonal. And our season is like a bell curve. So we really ramp up dramatically in the summer and then kind of scale down in the winter. I personally am a licensed physical therapist and a licensed acupuncturist with a specialty in sports medicine acupuncture. And our practice really focuses on, a lot of pain management, a lot of functional mobility, and a lot of, like I said, collaborative and interprofessional care.
And I'm Ellen Morello. I am our U.S. General Manager at EverEx. I am a physical therapist, and I have been in the kind of digital health side of PT practice for almost 10 years now, which is kind of wild. But excited to chat with Sue about how she's been using RTM at her practice. And yeah, thank you so much. Joe, could you share the slides for me, perhaps?
Yes, let me get those slides for you.
Zoom wants me to quit and reopen in order to share my screen, so I don't know if that's preferable.
No problem.
Unless you want me to drop for 1 second.
It's fine. All righty.
All right, super. I think we can skip ahead maybe 2 slides. Okay, great. So we are, here to talk mostly about RTM. It's as a tool to engage patients between visits, improve practice revenue, all of the wonderful things that Sue is going to share about how she's been incorporating RTM to improve her patient care and the health of her practice overall too. So Sue, maybe tell us a little bit more about your practice.
So like I said, we're mostly private practice, outpatient. I started as a physical therapist and then eventually saw that, physical therapy was great, but I wanted a little bit more. So that's why I became an acupuncturist to deal with the more global medical aspects and kind of like deal with the holistic part of somebody's musculoskeletal healthcare. We live on an island. So I don't know if you guys know, where Martha's Vineyard is. It's a small island off the coast of Cape Cod. The community here, it's very expensive. Real estate is expensive. And what my goal is to really grow and scale my practice really within the walls and the confines of my one location and really to maximize and create opportunities for us to scale and grow without having to expand outside of our walls, because real estate here is just extremely expensive, whether you're buying a building or renting commercial space. As well as, when I hire somebody, because the cost of living is so high, we hire them at the high end of the salary spectrum, and I think this is why Ellen has reeled me in. What is it? Innovation and invention happens out of necessity. And so out of necessity, I have gleaned every opportunity to use, telehealth, virtual health, remote therapeutic monitoring to really ultimately help us scale and expand our practice with the staff that we have within the confines of our building here. And I found that really just adding the virtual health, adding telehealth, and especially what we're going to talk about today is remote therapeutic monitoring and how it's really added significant value to my practice.
Awesome. Thank you, Sue. So before we kind of dive into RTM and kind of the clinical implications and practice implications, I do think it's important to review all of the RTM CPT codes, since RTM is an additional revenue stream for the practice. So everyone has a lot of questions about the CPT codes and how you bill for RTM. So we will have a few kind of concrete examples of how Sue has billed out some of these charges, but these are the current CPT codes for musculoskeletal RTM. The first category of charges is all about the data transmission. So these charges, the first one is 98975. This is billed once, and it is for the initial setup and patient education to get them to download the app and understand the app and understand what RTM involves. Then the next two charges, these are an either or charge that you bill every 30 days, and they depend on the amount of data that is transmitted back and forth. So data transmission, sometimes a new concept for PTs, but using a software as a medical device or using certain softwares, you are able to transmit data back and forth. EverEx, we are an FDA Class 2 software as a medical device, so that allows us to track all of these various data points that clinicians can then monitor. The purpose of the data collection is ultimately to monitor it so that you can review it clinically. So if you accrue between 2 and 15 days in that 30-day period of data transmission, then you would bill the 98985 charge. If you accrue more than 16 days of data in that 30-day period, you would bill the 98977 charge. Because all of these charges start with 989, when we talk about RTM, a lot of times we just truncate the 989 part and we'll say, oh, did you bill a 77? And by that we mean the 98977. So if you hear us use an abbreviation, that's what we're talking about. So data points that could be transmitted are things like exercise adherence, difficulty, patient-reported outcome measures, range of motion, symptoms, step count, patient messaging back and forth, all of these things that the patient might be doing to participate in their care plan remotely. Each one of those are tracked in the software and count as a data point. Then the clinician has a monitoring dashboard and will go in and review all of those data points and make adjustments to the care plan or message back and forth with the patient or encourage compliance with their home exercises. So the purpose of all that data collection is to monitor it. The monitoring time is billed on a calendar month, which is a fun nuance of RTM codes. But so these are based on the amount of time that the clinician spends monitoring the patient. The first charge is the 7-9 charge for the first 10 minutes. It does require asynchronous communication to bill for monitoring charges for the first one. Then if you get up to 20 minutes, you would bill the 80 charge, and anything in addition to that in 20-minute increments, you would bill the 81 charge on top of that. The 7-9 or 80 are an either or type of code, and then the 81 is in addition to that for time spent on top of that. We will go into some kind of tangible examples of all of these, but just wanted to kind of give an overview because the codes are something a lot of people have questions about when they get started with an RTM program. So now that we've got the kind of baseline, we'll get into a little bit about Sue's sort of pilot program with EverEx. And maybe Sue, before we get into some of the numbers, let's talk about how you thought about implementation, from how you selected patients and how you sort of operationalized your RTM program when you first got started with EverEx.
All right, so I'll use the example for, we have a chronic low back pain program. I don't know if any of you are aware, but Medicare now covers acupuncture for chronic low back pain, and we've incorporated that into my clinic. So that program goes hand in hand, obviously, with our physical therapy chronic low back pain program. So what I have done is designed almost like I don't know how old you all are, but do you remember the term clinical pathways? You guys probably aren't old enough for this. I'm aging myself. But creating a clinical pathway for chronic low back pain that specifically incorporates RTM into that. So, for example, if somebody's coming here, obviously everybody that is under the guise of physical therapy for chronic low back pain, they're going to get a home program, and if they're technology based, I mean, it's not rocket science. If the Medicare person can handle their phone and they know their Apple password, that's kind of baseline criteria for really any of our chronic low back pain Medicare physical therapy patients. However, when we have patients who have gone through the gamut of physical therapy, have had probably surgery, are still struggling with some chronic issues, and are now in the, coming in specifically for another service, notably acupuncture, we want to make sure that they're all moving and they have some kind of movement-based regimen without necessarily requiring them to go back into a full physical therapy program. Still might need them to do some movement screenings and stuff, but we've incorporated remote therapeutic monitoring into that clinical pathway to make sure that all of our chronic low back pain patients are moving. And that might, require an abbreviated like physical therapy stint, but not necessarily a whole nother course of care that a lot of these people aren't going to do because they've just had enough. So that's one example of how we've incorporated it into our chronic low back pain program, not only in just the physical therapy program, but also in our interprofessional and collaborative care pathway. So it's really kind of a trigger if somebody's coming in and they're not necessarily undergoing physical therapy for chronic low back pain. We will kind of route them back at least to just get them set up for an RTM monitoring assessment, because everybody that comes in, that they have to move every day. We know this. Chronic pain people, they have to move on a regular basis, and it's been really, really valuable. So that's one example of how we've incorporated it into our and streamlined that into our workflow for one specific diagnosis.
So within the low back pain protocols, within the app, you've created these protocols. So really, you just have to click a few buttons to get people set up on either, you've created extension bias programs or flexion bias programs so that everyone's kind of, it's pretty easy to get people set up on a protocol.
Exactly. And I'm using one example. Obviously, we can use remote therapeutic monitoring for everything. But considering that 50% of all the referrals that we get are low back pain people, what's been really nice is to develop a template within, a program within, I call it the Ultimate Basic Back Program. And it's a very nice structured program that's really good for everybody globally and it's been a really nice, exercise program to infuse into that.
Yeah. And you have other, you've been doing RTM with other types of patients outside of low back, but I think it's a really good example of like, hey, these are great people. We're going to identify these people that we think are fantastic. And we're going to make it super easy and streamlined to have programs in place. On the Medicare side, I think it's worth mentioning, because you were mentioning these patients that have acupuncture but they do need an open PT plan of care for RTM services. So just worth noting that for Medicare compliance as well.
Do you want me to talk about kind of my added value, like epiphany I had the other day?
Of course.
So as private practice owners, we deal with metrics. And one of the metrics that I've carried through for the past 22 years is, a typical course of care, you want to capture those 10 visits, right? A new patient is worth about 10 visits worth, worth of revenue. And let's make it a nice, easy number. Say 10 visits is $1,000, right? That we would hope to get during that course of care. When we do RTM, the typical course of care, an episode of care for the RTM is a 3-month, is a 90-day program, which is typically accepted by Medicare, and that's kind of like what I think is a standard practice. When you have somebody that is to the end of their treatment, and you have a 90-day course of care for RTM, those are 3 additional visits that you're adding as an added value to that patient's case, right? So then if we look at the screen and we look at the average monthly billing per patient as, 154, and it really could be anywhere between 130 and 154. That's a great revenue per visit reimbursement. And add 3 of those to our typical case for a new patient, that adds a dramatic, significant bottom line value to that patient for that one particular patient. And so that's, I think, a really great perspective to put onto the value of RTM. Not only for patients, so we talk about like the patient, the patient value and how they're benefiting. And we'll talk about that more, about how amazing it is for patient outcomes. But specifically, I'm sure you're all clinic owners. Like, well, we want to talk bottom line, patient care first, which is we're going to talk about how amazing it is. But the bottom line is that we're adding additional revenue that we wouldn't have never captured before, and it's $450 for a typical course of care for an RTM for those 90 days of care. That's a lot. That's a significant added value for that one patient.
Yeah, absolutely. Significant added value for the patient, significant added value for the clinic too.
Yes.
Yeah, dealing with the cuts. So maybe just we'll summarize some of the data from your pilot program. So in the first year, we treated it as a pilot program. This was started in 24. During the initial period, you enrolled 77 patients. Average billing per patient per month was $154 extra. Only 4 of the codes were available at the time of the pilot. So now with the new codes, I think reimbursement's actually probably going to go up because some of the criteria are less strict. But in that time, you received a total reimbursement of almost $15,000, which is, pretty great for a single location practice. That really is a meaningful increase.
And Alan, before we move on to the next one, we talked about the value for the patient and how just patient care, it really just adds a significant value. We talked about the revenue, the added value of the revenue, but one thing that I actually forgot to mention earlier was about how I utilized it as a retention tool for my staff. We just had an example of one of my staff was leaving. Her elderly mother passed away, and her elderly father didn't even know how to put his own suspenders on or use a debit card. So she literally pretty quickly had to like leave the island and move back home. And what we did is we actually incorporated and had her become our telehealth therapist, providing virtual care, as well as our primary RTM therapist. And that actually allowed her to extend her employment with us well beyond what would have normally happened if she had to just leave and quit as a regular employee. So it's, again, another amazing added value as an opportunity for retention.
100%. Yeah, everyone's dealing with short staff issues right now. So any way to retain people by building out your remote program is wonderful. So now I think we have a little patient journey that we wanted to share, sort of to kind of tie all of this together, how you created this, sort of fully virtual program for a patient. And, this is a patient you probably wouldn't have captured otherwise because they lived off island. And, but you've got a wonderful brand and provide excellent care. So you're able to kind of capture some extra patients off island. In this example, you had a patient very sedentary, that, you were able to treat. You were able to treat with not a lot of visits, but with consistency over time to really drive a major lifestyle change and major, clinical outcomes. So maybe just tell us a little bit about this patient and kind of your experience just driving this kind of like value-based care program.
Yep. So 70-year-old post total hip replacement, a few years prior. I think it was at least 2 years before, two or 3 years before we started treatment. Was my understanding is that this particular patient was really being encouraged to start exercising more. He tried riding his bike to get exercising. I mean, he had PT post, post-op, but was still really struggling with some pain, and was trying to start exercising again, like what his doctors and his therapists were telling him, but his hip just hurt when he tried to do his exercises. So we did a telehealth intake, we did virtual care, and with the primary intention of setting him up on remote therapeutic monitoring. And granted, we were doing a little a pilot study to see how this would work, and it was a amazing success. This was somebody that really didn't need to get in the clinic, and it was again one of those people. They were kind of done. Like they went through the gamut. They did all the therapy before. They did the surgery. They did the post-op, and they just weren't a super appropriate person to get back for a full course of care. Taught him a few things to do, during the day to really release his hip, get his exercises in, followed him and got him to just make some dramatic improvement. And now he's like a little avid biking exerciser. A non-exerciser, again, we instill good habits after 45 days, and we instill lifestyle, a new lifestyle after 90 days. And I really do think that the RTM program that we set up for him made a huge difference in his ultimate outcome, his pain relief, and his ability to participate in long-term self-care exercise.
Absolutely. And that you were able to drive that consistency, for 3 months where, like you said, this is someone that wouldn't have come in multiple times a week, really. So just able to kind of push forward those lifestyle changes, integrating into his lifestyle, and ultimately getting someone that was previously sedentary, much more active, healthier. So just a really powerful example. Now, so we've kind of got a summary of the whole care journey here, but maybe we'll get into a bit of some of the tactical aspects of how the RTM components for this case were built. So I think we've got that on the next slide. So in that first month, you would, and we're going to get into, Sue, I know you've really created a wonderful process about how to best bill. It sounds like at your clinic, you are doing, you enroll the patient, a full month later, you then sit down and you bill out the 30-day cycle charges and any previous monitoring charges, either from the prior month or the current month, that are ready to bill at that time. So maybe just before we get into this summary, let's talk about sort of your process and how you've accomplished billing without as much headache.
Okay, so just to be clear, one of the biggest barriers, I have been wanting to do it, remote therapeutic monitoring for a while, and really one of the barriers to really implement it, to kick it off, was my apprehension about the understanding the billing and the coding. And I have to say that I'm super grateful looking back at the opportunity for my staff person leaving, because it really was the driving force to just jump the gun and make RTM happen. And it's been so worth it, because once you get into it, coming up with a nice system that makes it so not scary, with the different, because there are different timelines. You can bill out the setup code immediately, but then you have to wait for other codes for 30 days. You have to wait for some other codes for 16 days. And it's like, where am I going? However, the system that we've created marks it on a 30-day cycle. And it's all based, our billing dates are all based on their enrollment date. Because then you can use then a 30-day cycle after that. And when you do that, when you bill out the RTM visits based on the patient's enrollment date, then within the next 30 days, so if you bill out 30 days after, you capture all the codes. And that's it. And that really takes the complication out of it. And the first month, those are the typical codes that we bill out. Month 2, those are the typical codes. The month 2, typically you have that extra monitoring code at the end because you're updating exercise programs. You're maybe chatting with the patient about what's going on, what they need, some progressions, any changes that they've had going on, with their program. And then reverting back kind of to that lesser time for that 3rd month. And in that system, using the enrollment date as almost like their anniversary date for billing has really made the process much more simple.
Awesome. No, I think you've really operationalized it. And I think that seems to be how a lot of our customers are sort of structuring billing so that they aren't having to do a lot of notes when different charges become ready. Within our software, we have a pretty robust dashboard that will tell the practice exactly when charges are ready to bill. So we've within the software, there are several views to track the codes that are ready to bill. You can look by patient, you can look by month. And then at the end of the month, you can kind of go through and see if anyone needs a call or if anyone needs just a few more minutes of monitoring time to satisfy that charge in that month. So everything is quite visible so that you've got the view within the RTM software, and then you've got the process that you are talking about, which is kind of putting the charges within the EMR. So overall, there's a way to make it successful and streamlined and easy to track. All right, awesome. So I think we kind of discussed this just now, but I think this is one of the big success tips for practices that are looking to do RTM, because the billing is a little confusing if you're not used to it. It's not, it doesn't follow the 8-minute rule. It's, we're talking about data transmission. We're not talking about, procedural time. So it can be a little bit confusing. So as Sue was describing, she's come up with a process within, her EMR and her billing operation to bill those maximum number of codes. You set your visit on that 1 month cadence, and then kind of tracking everything easily right there within the EverEx software too. Anything else to add on billing, Sue?
No. So like if we enroll somebody today, right? Enroll somebody today, track them. I know that on April 5th, that I'm going to send that visit out, and I will have, in provided that we do the monitoring properly and make our calls, that we will capture all of those codes within that 30-day period. So that's the nice, simple way to compact it.
Absolutely. And then I know I'm just gonna kind of going off here, but I know this is a question that we get a lot, but is the commercial landscape for commercial insurers. Are you only doing Medicare? Are you billing in commercial insurers? Maybe just a moment to touch on the commercial.
Yep. So mostly Medicare, because it's just easy. With the commercial insurance, we are doing some, but keeping in mind that we're super mindful about co-insurances and co-pays and how that affects, and making sure that the patient knows. So, for example, I guess this will roll right into our next slide. Mm-hmm. Just, for example, I enrolled a patient who had insurance, who was in such excruciating pain that she couldn't get to the clinic. So started her care with telehealth virtual care. I made her a very specific exercise program that I wanted her to do for that acute low back pain, because she lived a half hour. She lives up on the reservation for the tribe on the island, and it was a good 40-minute drive to get here, and that was not happening. And so that's an example of how we started, remote therapeutic monitoring. I made very personalized program for her, not only utilized the exercises that were in EverEx and RTM, but also made some, and we can talk about these, some personalized videos and some self-care instruction. And finally, after maybe 2 weeks, week and a half to 2 weeks, we were able to get her in the clinic. So that's an example. But when we do the commercial, you have to just be mindful of of the copays, the co-insurances, and I have utilized it, especially when, for example, somebody, patient shows up here and they're like, I'm leaving to go wherever, or I'm leaving on a trip, and when you live on an island and you have sciatica, you have to get on a boat, get on a bus, then get in your car if you have, a car somewhere, and then drive somewhere. And there's to go anywhere. It's a 3-hour endeavor. And so when someone's having pain like that, we actually have set them up again on another virtual care with telehealth and then remote therapeutic monitoring. So with the commercial programs, we're a little bit more episodic and more specialized. It's not just everybody across the board. Kind of like with Medicare. Medicare, my goal is everybody that has that can use their phone and they can upload an app should be getting RTM, because it's just good for them. Commercial payers were a little bit more selective.
It seems like that's
still valuable.
Yeah, seems like that's the kind of case across the board, since the commercial landscape is a bit more variable. I think I love that story about that patient, because I love virtual care and how it improves access. And that's such a prime example of a patient that would not have been able to access care if there were not a virtual offering for her available. So that story always gets me really excited. So.
Yeah, and I swear she would have ended up in surgery if we weren't able to get that intensive care, like even before she was able to get in the clinic.
Early access.
Yeah, early access is huge.
Yep. It's just such a concrete story, and what a great success story. And so to the point of this slide was sort of personalizing care. So for this patient, you created a care journey that accommodated her needs. You've also done quite a few things within your RTM program to really make care personalized, including some like custom videos that you've made. So maybe let's talk about a little bit of the extra content that you've developed for patients.
So what the pattern that I'm seeing with our remote therapeutic monitoring implementation is we kind of give them their initial, the initial exercises that they're doing to get started. And then as they progress kind of the second month, I found that we're taking more specific videos of them doing their routine, because, they're, at that point in the second month, they're kind of like, they know what they're doing. And so what I've done is I've done specific videos of the patients doing their own exercises. Sometimes they refuse to have them self-done and they make me do the video, and I do the exercises, but my preference is to take a video of them doing that themselves. Speaking to the form. So we've done some, custom video exercises. We've done some, custom care with like self-care. So if we're teaching somebody a taping technique or a soft tissue technique, then we're also adding those types of things, those types of instructions as well. And I find that patients are actually a little bit even more compliant when you do those personalized, the kind of those personal uploads.
Yep, absolutely. I think it builds a stronger rapport, that they know that they're getting care that's specific to them. So within our software, there is a feature to upload your own content. So this is what Sue's talking about, and people are using that either for niche exercises or patient education. I think you've even created an entire like fitness routine that patients can do as like a little mini workout class, which I think is another really fun way to use that feature as well. So great tidbit about getting patients more engaged with the content. I think we have, so this one is, I'm sure, one that a lot of practice owners are wondering, which is really, how do you get your staff excited to participate in RTM? How have you sort of structured it to make RTM not feel like one more thing that the staff have to do, and kind of get them to also participate?
So and we're still on the tail ends of our pilot program. I think eventually, I do think RTM is going to be really a mainstay in any performance-based, incentivized salary program. Where clinic owners, if they're tracking, it's a revenue-based salary structure with their staff, this is going to be a huge help in keeping their staff engaged with that, because it's ultimately, again, adding to the bottom line. What I have done with my current pilot program, because it's, especially when it's new and you're kicking it off, it is like pulling teeth. If I see another, I hope there's no Medicare people here, but if I told my staff, I go, if I see another Medicare person that is tech capable and getting a MedBridge program, I'm going to cancel our subscription. So it is hard to get that buy-in. It just takes cadence and practice and momentum. And one way that I've been able to at least get people into the habit of having RTM on their mind is one particular staff person. She is 30. She's wanting to save for a house, and she was looking to take on a second job, which I don't know about you, but our new grad home, physical therapists, a lot of them are doing home care as a side hustle, just to get that extra cash on the side, and that's what she wanted to do. And I showed her, I came up with a percentage payout where we split. So basically, I brought my therapist on to do RTM as a side hustle, set it up as a kind of a partnership model. We split any overhead for any enrollment fees, and then after that, we split the percentage, kind of typical of almost like an independent contractor. And so she gets a percentage payout of the revenue that comes in after we split any enrollment costs. And her goal, we wanted to make so much money. So ultimately, her goal is to have 7 RTM patients on her schedule at any one time. And this is over and above. This is like a little part-time job on the side. And that's how we've started to kick this off. I think eventually, it will be part of an overall performance-based thing. And once I think our staff hit their specific goals, then to implement that. But as far as like this particular case goes right now, again, another opportunity for staff retention. I didn't let her escape to run off to go do, 5 or 6, VNA visits after she leaves here. We kept it under our roof, right? We're scaling. We're growing the practice within the confines of keeping the staff under our roof, and giving our patients a little bit better care too by implementing the RPM home programs.
Thank you so much for sharing, Sue. Yeah, we have other clients who are kind of the incentives may be tied to number of units billed, or they may have sort of like digital health bonus programs. So that there's potential monetary incentivization since they are billing extra charges with RTM. But we also know that really PTs go into PT because they love helping patients, and we love good clinical care. So another kind of component that we've seen helps encourage staff is sharing some clinical literature about the success of RTM programs, and kind of showing some real patient data. So on the next slide, there is a summary of a popular study about RTM, and large scale study that there was a cohort that did PT alone and then PT plus RTM. The cohort that did have RTM added to their care had better functional outcomes, and actually were more consistent with their course of care. So there is strong literature to support that RTM can improve clinical outcomes. And then I think on the next slide, we're going to really kind of give an example of your data, Sue, of the pilot program, where the patients that had RTM were logging in about 58.71 times on average, which is really great that they're kind of going to the app frequently for, their exercises, their communication. Over 1,500 workouts completed, which is really amazing to think that like patients are doing that much exercise at home with the addition of RTM. You had a lot of messages sent, 406 minutes of monitoring time. The step counter was utilized as well. And then the clinical outcomes, these are meaningful clinical outcomes in pain reduction and increase in range of motion. So overall, we are seeing good clinical outcomes, good engagement with the addition of RTM. Anything you want to add here, Sue, in terms of the sort of clinical and engagement results that
No, and these, I have to say, these are very conservative numbers too, because that was really the first kickoff of our program. I would say it's going to be even dramatically more, even from the time. I think these we stopped tracking this I think in the summer, and I think even before, like we've gotten even better at it now, and our patients have gotten even better. So I would say these are like actually even conservative numbers, and the outcomes are getting better and better.
Right, exactly. And again, these are averages, so there's outliers in every direction, but it is exciting to see it's meaningfully moving the needle. All right, I think just to start sort of summarizing and kind of wrapping things up so we can move towards the Q&A portion, you've alluded to, kind of thinking of the patients that are the best fit for enrolling in RTM. You've kind of structured your billing process. You've got your staff bought in, incorporating RTM as evidence-based care and personalizing care. These are all just kind of some of the topics that we've touched on that have helped you make the RTM program successful at VCM. Anything else that you want to elaborate on here, Sue?
Yeah, when you're giving your spiel to your patients, or what I find is when we're really talking to patients about what it is, what I found has really hooked them in is one, when you explain to them that this is a covered service by Medicare. And as soon as you say that to a senior, they like, what? Like they spark their eye, they get a little sparkle in their eye. And then you tell them the criteria. Medicare will cover it if you do this, do that, and do that, and you give them very clear expectations. And then what you do is they're like, well, I'm just, especially with someone like, again, with any chronic issue, my kind of what I tell my patients is like, this is a long-term project. Anybody that's in the Medicare population that's had a chronic issue, like this is months of consistent attention to this. And what RTM does, if you say, this is going to help us help you be accountable. Like we're going to be your home exercise coach, and we're going to be there. We're going to be available to you. You can text us, you can message us. We're going to be monitoring you, and this is your accountability plan, and we're your coach. And when we're presenting it, and when we say the word, I'm your accountability coach from here on in. When you start weaning yourself from the clinic, the remote therapeutic monitoring is allowing me to stay engaged and support you and be a little bit of a big brother to make sure you're doing your exercises. End of story. And that's been really so right from the beginning, you tell them that Medicare covers it. You tell them the criteria. Medicare will cover it if you do this and this and this and this. and then tell them that, ultimately it's about, creating that habit, creating that cadence of accountability, and making sure that they keep up the momentum. And if they can keep up with that for that 3-month cycle, then you can be like, then it becomes your lifestyle, and it's not so hard to participate in. So I found that whole, like, from beginning to end, that really just creates the buy-in from the patient.
Yep, absolutely. Which is so important, really. You have to get the patients bought in to get them engaged, and that is a barrier sometimes. So I think, we provide scripts to our customers too to help them with patient buy-in. As Sue pointed out, there's a lot of bullets in there. If it's a covered benefit, the access to messaging between visits, I think, is a powerful one too. And that accountability piece, like, hey, I'm going to actually be looking to see if you've done your exercises. Please give me that feedback. I want to know what's working. I want to know what's not working, so that we can adjust your program, and we'll progress things as you go. So giving all of those talking points to the patients, super important. I think we've maybe got one more slide, and then we can move on to the Q&A portion. But I think you kept things simple, knowing the criteria, creating some protocols, getting your staff on board, starting small. That pilot program was, we extended it over a longer period of time, but just to really get that change management, work out all of the pieces and parts, and kind of scale up from there. As you said, now you're much more efficient with it. You've really got patients much more bought in. We're tracking all of the data, within our software, and kind of monitoring all of the performance of the program, and then also kind of monitoring the reimbursements and the success. So
yeah, it's, just as one takeaway, and I don't know how many are clinic owners out there that are participating in this versus clinical directors, but I just see that the using remote therapeutic monitoring and using virtual care is just really going to be, I think, a mainstay of us as for outpatient private practice. We're going to be consistently fighting with legislation, and are we going to get cuts, and what percentage of cuts, and the Reduction Act, and there's always going to be something. But yet, as clinic owners, like, what is the baseline goal? We still have to grow every year, right? We still have to, our goal is to grow between 3% and 5%, despite the fact that they're taking money away and opportunities for us to, get that reimbursement. So we're expected to grow, and we're expected to be profitable. And this is really, I think, just a really crucial way for us to fill in those gaps when, when the reimbursement world isn't going to be always on our side. So I think this is a really great, innovative way for us to just plug in where those, like, missing pieces are, and still allow us to continue to grow as practice owners.
Love that. I think we do have time now for some Q&A. So we will open it to the audience now for a few minutes of Q&A.
All righty. And our very first question is from Mary Walsh, and she asks, is there an issue when your patient leaves the state of Massachusetts when you want to continue RTM due to licensing issues?
Do you want to take that, or do you want me to take that on?
You can take it.
It's their primary residence that counts, is really ultimately. So if they're on a trip and they're traveling and it's a temporary, right? Correct me if I'm wrong. It's about their primary residence. That's what counts.
And you aren't, I think the key component too is that you aren't providing any synchronous services. So it's not a telehealth visit that's happening during that time. They can stay on program, but any synchronous care is happening in the state of Massachusetts, right? So that when they return to Massachusetts, that's when you would have video visits or in-person visits, or
right.
Any synchronous,
which is separate. So telehealth is separate and different, and has different rules than RTM. Right. So just to be clear. Right. So Yeah, so as long as, so really the ultimate thing is as long as they are residents and they are a Massachusetts or they're, within the state and they're still a resident of that state, then you can continue to do remote therapeutic monitoring.
Right.
You wouldn't be able to do telehealth
Right.
if the patient was out of state, but you can still do remote therapeutic monitoring because of that asynchronous criteria.
Yes, thank you so much.
Another question we have is for Sue, actually. Before implementing RTM, what gap existed between patient visits that made you realize something needed to change?
Well, I mean, our reimbursements have gone down. I think mine have like gone down like 20 something percent since 2018. I don't know if y'all been tracking that, like, with the, with all the reduction acts and everything. So that's where, and this, Martha's Vineyard, like I said, we have to hire people at like the upper percentile of salary ranges because our cost of living here is 79% above the national average. So that's where I was seeing the gap is like my staff still wanted to make more money. And yet I had this huge, this gap that, with all those changes that happened between, I think, 2018 and now. So, yeah, you should see the reimbursement. I don't know if you guys have tracked your stuff since 2018, but it's like, it kind of like chinks down every year, from overall. So that's the gap that I'm seeing. So, we're getting, less money per visit. That the Reduction Act really changed things dramatically. As well as now you're getting a lot of these, some of the Advantage plans that you can only get so many visits. And then even if the patient needs more, then you can at least still extend them with the RTM. Did that answer the question about the gap?
I'm assuming it does.
And then God forbid if you've got like blizzards and cancellations and some of our patients get stuck off island and they can't make the ferry over. So that's when we've so it's not necessarily to affect RTM, but that's when we would kick in more telehealth and more of that the virtual care theme.
Yeah, you've mentioned
just
before
plug it in whenever you can.
that leaky funnel, using these tools to help with that leaky funnel of.
And then another opportunity when your staff does have a blizzard, like we did last week, or something's going on, like guess what? My therapist during those cancellation times was, when she had electricity, she was doing her remote therapeutic monitoring, tracking and updating the home programs, and it's another way to kind of fill in those that opportunity to create more productive, I guess, time during your staff's day.
And I think we have enough time for one final question. At what point did you realize RTM was not only supporting care beyond the clinic, but also creating meaningful revenue for the practice?
Just look at the bottom line. That's like $15,000 I never would have had last year. Like, that's amazing. And that's actually giving me hope for the next couple of years as a practice owner, that I can still achieve those wildly important goals of continuing to grow at a certain rate and then actually maybe make a profit as well. So that's where I see the big value of RTM, and that $15,000 is going to be a very conservative number, because that was just in our pilot program getting started, kind of working out the kinks. And as you get through it, I would say after I would say 6 months, it really took for us to just feel comfortable with the processes, monitoring the claims, just really figuring the nuances, and it's here to stay. Virtual care and technology is here to stay. Figure out how you're going to incorporate it.
And that the codes are only expanding is a really good sign too, that RTM is here to stay, and they are only going to be putting more resources into RTM reimbursements.
Mm-hmm. And Sue, another question, sorry, before I say the last question, but what made you choose EverEx over other RTM companies or EMRs that supported RTM?
Mhm. Well, I don't know. Am I allowed to say names? Well, so when I started shopping around, we went with one company that was like, I won't say names, but it was like, okay, you're going to give us, $500 a month. You guys can probably figure out what it is, and we're going to do your billing. We're going to do all the things, and they kind of blew us off because we weren't big enough. They were like, meh, meh, to they were we were, so we tried to go with that company, but we were you know, I guess just too small and didn't have enough volume. We looked at I would say we looked at probably like three other ones, and ultimately, well, full disclosure, I chose EverEx. Well, I know about EverEx ultimately because of Ellen. And I've been working with Ellen for a long time. And I like Ellen, like is all things like virtual telehealth. She is the queen. But we did shop around, just so that we could just at least have some, just do some product research. And ultimately, it was the customer service, the coaching that we got from the EverEx team, and the response and like I said, ultimately, it's the customer service / the coaching and the training and the teaching that the EverEx team provided us that I think is just amazingly exceptional compared to everybody else. And it's just well worth it to work with this team. There are opportunities like, I know RTM programs are embedded into other EMRs, in different instances. I would say just based on with the system that we've created for the billing and streamline that, it makes it so worth it to work with this team because of their coaching and the customer service.
Thank you, Sue.
Thank you, Sue. Is there any closing remarks that you have for the viewers that are watching right now before we sign off?
I would say, why did I work with EverEx? Is that I trust Ellen so much, and I think allowing being able to work with your team just took the fear out of just jumping in and diving in, because because that like kind of that not fear, but that barrier of like, oh, it's complicated, and was really kind of taken away just working with you guys. So, yep, highly recommend you guys and your team.
Thank you, Sue.
Ellen, anything from your end as well?
No, thank you so much for participating, everyone. You can find us at everex.ai. You can find Sue, Sue, if you want to share any ways that participants could find Vineyard Complementary Medicine. Just thank you so much for making some time today.
Yeah. You guys are a great team. They'll give you whatever you want.
Thank you so much, Sue.
Uploads. Yes. Thank you, everybody. Thanks for the time.
Thank you for everyone for joining. We will have the webinar uploaded on our YouTube channel and website by tomorrow. With that being said, have a wonderful day, everyone.